psychology students, we are looking at week 30. I'm making the video for the week 30 video assignment. First, while I'm here, we're just going to look at what you're doing this week. We're going to do the same as we did last week, where we have some practice doing the diagnoses. I'll go over that again because we did some new diagnosis last week. You're going to switch from the diagnostic criteria and the causes of mental illnesses to the treatments of them. So you're going to look at insight therapies, you're going to look at behavior therapies, cognitive behavioral therapy, and biological therapies. And we're going to look at today how often we mix these a little bit, we intermix them. I put lots of practice multiple choice questions up here for you. And I don't think we're going to have time for that. So that's where we are. Let's switch over to our slide. So life isn't fair. Most of the stuff I worried about over the years never even happened. Oh, how I have this discussion with my third daughter over and over again. Just on Sunday night, it was German test I'm going to have tomorrow. I'm going to have this German test and it's going to be so bad. And she starts to go so fast. And I said, well, what if you don't have a test? Because she didn't know for certain. And then she came home Monday and she's like, I didn't have a test. And I said, I told you so, right? So as best as we can to stay in the present. So we looked at our schedule all week. We're going to look at the diagnostic criterias you looked at last week. We're going to have a little short discussion over the treatments, more of what you're going to cover this week. I'm going to point out just something little on hypnosis to make sure you got it. Then you're going to do the discussion forum, and there's a week 30 quiz. So the diagnostic criteria you had last week, right? You might pause this video and not look at what's over here and just write down personality disorders, schizophrenia, childhood, and dissociative and see, do you remember much? Right? I hope you remember from personality disorders that we really have these two clusters. This is the best way to remember these. Cluster A is the more eccentric clusters. These include paranoid, schizoid, schizotypical personality disorders. And cluster B are the more dramatic or emotional ones. And this is antisocial, histrionic, narcissistic, and borderline. Remembering back to when we talked about these 5 axes of diagnosis, that personality disorders are on axis 2, meaning that oftentimes you might have somebody presenting with depression and narcissistic personality disorders. And the big difference between the two is that personality disorders, most of the time, the person can't, these are things that don't tend to change. Sometimes you can help a person balance them or come to really with a lot of work on consciously understanding what happens, but they often do not see that their personality is causing them problems, right? So it's probably the most difficult, you ask any therapist, the most difficult is borderline personality disorder. But often people who have, narcissism is very common in childhood and most people grow out of it. But to the degree to which it becomes part of a person's personality, it's very hard for people. And oftentimes people with these more odd and eccentric personality, they won't even seek help because they don't recognize that anything is wrong. Another thing to make sure you're keeping, in movies, we often put these dissociative disorders and intermix with schizophrenic symptoms. Kind of the big thing that'll help you is schizophrenia is a really genetic biological problem, and dissociative disorders are really due to often severe childhood abuse, right? So usually it's dissociative in terms of protection of the self. And so young children who may be sexually abused often report remembering it as if they're not in their own body. And then this ability to kind of separate from your body can become a bit persistent as a way of like let's say you or I became scared and we didn't have this abuse, we might flee or try to fight from that or freeze when we're afraid. But somebody who has gone through significant trauma might completely dissociate, meaning that they don't even feel like they're in their body when they experience a stressful event later in life. So big difference on those two. Childhood disorders, we're really talking about autism spectrum disorder and ADHD, and kind of the ongoing debate of, is ADHD a disorder or just kind of a normal way the brain functions? We talked about that a little bit last week. So these are the disorders you had. These are the disorders from last week. So this week in the project or in the discussion, you're going to focus on these and just follow the directions the same as you did last week for that. I want to talk about first, bring this to the front. I have two things here. One, I think it's a really good idea to have a general timeline in your mind of what has happened in the course of treating mental illnesses. So we have really early, we're looking at before 1700, this was mental illnesses were thought to be caused by evil, right? Demonic, so exorcisms, there's really no form of treatment, maybe looked at more of a punishment, but we don't really have treatment before then. Then we get to a whole period of time of pretty inhumane treatment, where people are kind of locked up, or maybe they're forced to vomit, or they're bleeding treatments. It's really no understanding of the mental illness that's happening. We have industrialization. So in this, why does this matter? Because we focus a lot of improvements in science and medicine, but we also go from having people in small, relatively small villages where maybe, they're ostracized by their community, or maybe they're just looked at as very odd within their community. They're still sort of taken care of as best as possible, or kind of kept in really small environments. With industrialization comes these bigger institutions for people with mental illnesses. So a lot of these are run by the states. They're not run very well. You can still find this around Europe, not so much in the US, but just about 30 minutes from my house is still a place that is, just, you don't know what to do, and people are just put there. In the US, you end up having this idea, I'm going to skip ahead and come back, of deinstitutionalization, where these institutions are almost all shut down. And because of that, we end up seeing a lot of mental illness being treated in prisons in the US. So there's, just because these institutions were not run well, we had a lot of people come say, wait a second, we have to be more humane, right? We have the whole, everything you've learned about from 1900 on is of treatment. We get in the 1950s, we get a lot of medical, right? We end up with hospitals that focus only on psychiatry. We have so many medications, and then we say, okay, we don't need these hospitals at all, or these institutions. The problem is we still have a significant population of people who need mental health treatment, and I'm not saying that we can do that all that well. There is a, where did my little Rosenhan, here we go. This little term here, bring it to the front. I want this right here. Oh, and then we have these, I was saying we have drugs, we have present, we're trying to do everything. But in around the I think it was started 1970s, before it really sparked this deinstitutionalization, and it's a study to know about. It's also called the Thud experiment, because Rosenhan and a whole bunch of people went to different hospitals. So they went in to the hospitals and they said, I hear someone saying thud. That's all they said. They didn't say they were going to hurt themselves. They just said, I hear somebody. And so they were all brought into the hospital. They were all given, or mostly given, a schizophrenic diagnosis. But as soon as they were in the hospital, they said, I don't hear it anymore. And there's, on average, I think they were kept a little over 3 weeks before they were released, even though they had no other symptoms. And a lot was discussed about how normal behavior, once you say somebody's schizophrenic and they're exhibiting normal behavior, that normal behavior is interpreted as being abnormal, and they were kept longer. It's interesting that this study was redone recently by a different person. I'm just moving Rosenhan over here. And they did the same thing except with medication, right? So we still have a hard time understanding human behavior if we've classified it as abnormal or given it a diagnosis. So we need to be really careful for that. And so we can see how these treatments have really changed. Currently, like if we jump to the present, so how are illnesses treated? We have this really kind of overlapping, oops, I don't know how I made, there we go. We have this overlapping set of things. So we have mental health here, and all, if our social environment, if our biology is going well, if our psychological health is going well, right? So beliefs, behavior, personality, self-esteem, coping skills, how we handle emotion, our social skills, right? If we have the right kind of social support and resources and relationships, if we don't have to deal with maybe some genetic problems or some physical health disabilities, we get to have life events, family relationships that all go well, and we call this mental health, right? We can see that all of these factors have to be taken care of when we're talking about treatment of mental health, right? So it's not, you can't just do a genetic test and say, oh, you have a genetic predisposition for this, or, oh, your neurochemistry is bad. No, we need to look at what's going on in the family, what's going on with peer relationships. When we talk about personality disorders, right, it's what's going on with the personality. So we have all of these things working together to help us achieve mental health. Okay. And we should really keep in mind that oftentimes it's not so easy to say mentally healthy, mentally unhealthy. It's usually a continuum. And oftentimes we can, like if we think of like a teeter-totter, right, where one side down is mentally health and one side up is mental illness, trying to find where we're not teetering back and forth and we're finding balance in the middle sometimes can be tricky. Just as a kind of, this is APA, American Psychological Association. I think it's good for you to see what they will tell you is best practices in psychological treatment. You might see some multiple choice questions on this. Right? We want no harm. That's probably the non-malfeasance is we want no harm. So they should benefit and you should not harm them. And sometimes this is really hard to measure because most patients won't come in and tell you, like it's very hard for somebody to come in and say, hey doc, I don't think you're doing a good job, right? So you need to think about a way to maybe measure this. There's a lot of clinicians going to like anonymous surveys to kind of see more of what's going on. Fidelity and responsibility is that we don't want to exploit others and we want to try to be a citizen in that community. This can sometimes be very difficult. I'll give you an example. Is when I was doing my master's degree in psychology, I was at Cleveland State University, and we worked in the inner city Cleveland to do support services there, or I also worked at a school there. But I was not a member of that community. I was not a citizen of Cleveland. I didn't grow up there. And this is a big issue where you have people living not where they're working, right? So it's a hard thing to do. You need to try to be more active in the community, and to the extent to which you can be a real citizen of that community, it's a benefit. Integrity, I think this is obvious, honest and truthful. Do not cheat or steal. Be fair. Remove bias. This is a difficult one because we grow up with different sets of cultural identities, and sometimes it's not easy for one person to understand how others accomplish things, right? Privacy and confidentiality, right? You go over confidentiality with your patient right away. When you're working with young people, this is especially important if they're not adults, because you want a child to be able to talk to you, but you are responsible to their parents. Right of self-determination. This means that the person has to choose. Sometimes people don't choose the treatment you want them to choose, and they have that right. And last, cultural respect, right? Like we've talked about a lot, to understand the differences between how cultures view problems or just situations. All right, a little bit here on hypnosis. I really recommend that you watch on the College Board topic 5.5 because it talks about hypnosis. I'm just going to say two things here to point it out because I think it'll help you. Hypnosis has shown effectiveness in treating pain and anxiety There is no research to support hypnosis to retrieve accurate memories or to regress in age. So if you're trying, like somebody's trying to say to you, I'm going to help you, remember something when you were younger, hypnosis often creates false memories. So it's not used in that way, but it can be helpful in treating pain. All right, so what you're going to do is you have these disorders. So you can practice just like we did last week. The discussion forum is on the course page, and you're going to do the week 30 quiz on the College Board. So upload any notes you took, and then upload your results from the quiz. Thank you for watching week 30. Have a great week.